Good morning, everyone. We are grateful and very honored to have three wonderful speakers. The first one is Dr. Shackle. She joined the anesthesia department at Vanderbilt University Medical Center in 2018, serves as the rotation director for the main OR rotation. Her academic efforts are focused on teaching medical students, residents, and fellows, with an emphasis on regional, acute pain, and transthoracic ultrasonography. She's also part of the new education effort as co-director of the point-of-care ultrasound program. Please help me welcome Dr. Shackle.
Thank you. Good morning, everyone. Let me just see, get the clicker. Okay, so as it says up here, we're going to do perioperative gastric ultrasound. Let me see if I can move this. There we go. And I see a lot of you are enjoying your breakfast and coffee, so unfortunately we don't have any ultrasounds to scan anybody today, but I'm sure we would definitely see some interesting things. So. All right, let's get started. So I don't have any disclosures. So, as we kind of go through things today, we're going to start, kind of at the basics here, and we're going to review some of the relevant anatomic structures. And of course, we're going to do that in order to understand the relationship for gastric ultrasound. And then we're going to discuss the process of actually acquiring the image, including how to do the scanning technique and what we're going to find, our interpretation of findings. And then finally, we're going to hopefully, apply some appropriate applications of gastric ultrasound, and then I'll kind of discuss some of the caveats, some of the limitations of gastric ultrasound. So I don't need to remind anybody in this room, but aspiration pneumonia is a risk of anesthesia that has been present in our specialty for a long time. And despite many of our amazing advances in our practice, is still a very real risk and real threat to our patients. Looking in the literature, there's a wide range of incidences, from less than 0.1% to as high as 19%. And of course, this is depending on different patient factors. Around 1% is what, I've seen for most of our patients, when they're coming to the operating room. Just a reminder, aspiration is a leading cause of death for airway events and does, account to up to 9% of all anesthesia-related deaths. So this is a real problem and something we really need to pay attention to. So just as a reminder, what factors need to be present for aspiration to occur. Of course, there needs to be sufficient volume in the stomach for that to be regurgitated. There needs to be decreased tone of the lower esophageal sphincter. And then we need, suppression of the upper airway reflexes or absent upper airway reflexes. And obviously, I don't need to tell anybody in this room this, but general anesthesia, of course, impacts, decreasing the lower esophageal sphincter tone and blunts our upper airway reflexes. We all know this. And so this puts our patients at risk of aspiration. Now, the one factor here that we can modify, of course, is the gastric contents. And so, that's what's helped our societies, develop these evidence-based fasting guidelines. So we're all very familiar with the ASA's fasting guidelines. We utilize these every single day in our practice. And, although they're great, they don't necessarily apply to all of our patients. And I think we all have seen that in our practice. And the guidelines, if you read them carefully, even indicate that, they're guidelines, and we must use our clinical judgment. And so, aspiration events occasionally occur in patients who have strictly followed these guidelines. The patients that swear, I had nothing after, midnight, nothing after 10 p.m. And you believe them, What it basically highlights is that there can be variability in gastric emptying among patients, especially in patients with certain comorbidities. And we've all found solid gastric contents in patients despite complying with these guidelines. So we're making clinical decisions, regarding surgical timing and airway management based on these assumptions that the patient either has an empty stomach, has followed the guidelines, or they have a full stomach. And that may not be, enough in certain situations. So what if we had another tool? What if there was something else we could use, to help guide our practice? So point-of-care ultrasound in general, especially in the cardiac and lung realms, has become a very useful tool in obtaining clinical information at the bedside to answer well-defined clinical questions to ultimately alter anesthesia management. And of course, the big driver of all of this is to improve patient outcomes. So who can you use gastric ultrasound for? So patients with questionable MPO times, those that may have violated, or those where reliable MPO status may not be attainable. Now, of course, I'm not advocating throwing away the ASA guidelines. Obviously, we still need to very strictly follow those. So this is not in lieu of those guidelines. This is more for maybe patients who, have a language barrier or, have severe dementia, and you're really questioning, whether or not the patient has actually followed those fasting intervals. Patients with delayed gastric emptying, whether that's due to an emergency condition, diabetes, opioid use, and also even considering patients with advanced hepatic dysfunction, patients with significant neuromuscular diseases like Parkinson's or MS. I think we all know this, but symptoms of gastric emptying, have very low predictive values, so you can't rely on your history taking in order to determine if a patient has severe, issues with gastric emptying. It's very difficult to just, discern that by just taking the history. And this is, I believe, where gastric ultrasound can help. So gastric ultrasound is most useful when there's true clinical uncertainty. So this is another big point. So not throwing away ASA guidelines. And then we really can't apply this to healthy patients who follow the guidelines, who present for surgery, okay? We want to utilize gastric ultrasound when we have a pretest probability of a full stomach around 50%. This is what they say in the literature. So not, advocating for routine use in healthy patients. Okay. So in order to kind of understand what we're going to see on the ultrasound, we need to kind of review some of the anatomic structures in the area. So just to kind of point out a few things here, we're going to kind of go through the different aspects of the stomach so we kind of know what we're looking at here on ultrasound. So as you can remember from medical school, on the anatomic left from top to bottom, you have the fundus, then the body, then the antrum, and then finally the pylorus is the most distal structure, and that you can see labeled here on the right. What we're going to be looking at is the gastric antrum, which is the part of the stomach that is most amenable to ultrasound, kind of given its location in the body. And you can see here on the screen, I kind of drew a blue line kind of right down the center where the antrum is. The antrum is at the lower left lobe of the liver, and it has, you can see a little bit of the pancreas, and then the abdominal aorta is like right behind it. And then just also wanted to mention here, remember way back from medical school that the gastric wall actually has 5 layers. And the reason I point this out is we want to be able to differentiate the stomach from other hollow viscous organs like bowel. So there's 5 layers, and you can kind of see this on ultrasound, okay? So what is it going to look like on ultrasound? So here we have a still ultrasound image, and I've kind of outlined the important structures, okay? So you can see the gastric antrum is at the center of the screen. It's a thick, multi-layered organ, as we talked about, has 5 layers. And you can see that it's sitting immediately inferior to the left lobe of the liver. And that's the structure outlined in green. And at the bottom of the screen, you'll see we have some vasculature. There's the abdominal aorta in long axis, and then occasionally you can see either the superior mesenteric artery or vein. So I have another example here of an exam. In this example, you can see more of the liver there, kind of on the screen there, and the stomach again is at the just inferior to that left lobe there. We can see the SMA, and then the aorta is more clearly defined in this image. Okay, so how do we get the images I just showed you? So, we're going to start by selecting the right probe. So you're going to start by selecting a low-frequency curved array or curvilinear probe. I have also done this with a phased array probe. If you don't have, your phased array probe is obviously used for cardiac and lung ultrasound. I have used a phased array probe, but it doesn't give as wide of a view as a curved probe, given its footprint. So best if you have a curved probe to use a curved probe. You're going to start by scanning the patient in supine, and then you're going to move them into the right lateral decubitus position. And now that's opposite than what we're doing for our cardiac exams, where we want them on their left side. So for gastric ultrasound, you're going to move them onto their right side. And basically what this does is it allows gravity to displace a larger portion of the stomach contents towards the antrum. Okay, we want to fill the antrum because the antrum is what we can see on ultrasound. So we want everything that's in the stomach to move to that side so we can see it. If you can't move your patient into the right lateral decubitus position, which is sometimes unfortunately the case, whether that's due to critical illness or they have an injury or they're in spine precautions and you just absolutely cannot move them. You can, if they will allow you to adjust the head of the bed, you can do an semi-recumbent position with the head of the bed at 45 degrees if you're allowed to lift the head of the bed up. This is not as sensitive though, so if you are not able to move them onto their right side, you need to take your findings with a little bit more grain of salt, because what you're going to see is not going to be quite as sensitive as if you could get them on their side. So we have an image here of exactly what this looks like. So you can see the patient here is on their right side, flat, and we're scanning in the sagittal plane. We have the probe indicator towards the patient's head, and then we can't see, what they're doing with the ultrasound machine, but the operator has placed the machine in an abdominal preset mode that you may have on one of your machines. Most, especially if you have a curved probe, most machines are going to have this just basic abdominal preset mode, and you can use that. And what that does is that's going to obviously do some optimization of your image window and all that, but most importantly, it's going to put that indicator or the marker on the screen on the left side. Okay, so that's important because if you have it on the other side, that your image is flipped. Okay, so important for that to be on the left side, and then when you have your probe in that sagittal plane, your marker is towards the head. So we've already kind of looked at some still images, but now we're going to kind of look and see, what are we going to find in these patients? So if we have a patient where we are very suspicious, our pretest probability is above 50%, they may have a full stomach, what are we going to see when we put the probe on? They may have an empty stomach. So this is a still image of an empty stomach. As you can see here, the antrum, again, just inferior to that left lobe of the liver there is empty. It appears small. You can see the thick hypoechoic layer surrounding it. That's the muscularis propria. It's one of the 5 layers that we looked at earlier. And you can see that the stomach appears relatively thick because the anterior and the posterior walls are next to each other. And this has been described as a bullseye or a target pattern. Okay, so everything in point of care ultrasound has a cute name. In lung we have sandy beach and, barcode sign, if you guys are familiar with any other types of point of care ultrasound. So for gastric, we have the bullseye, okay? That's an empty stomach. If your patient has secretly just eaten a sandwich in pre-op, you might see this. So after a solid meal has been ingested, you'll get a linear hyperechoic area that you can see along the mucosal of the anterior wall of the antrum. And basically what this does, this is a reverberation artifact. This creates a ring down artifact at that mucosal air interface, given this appearance of kind of like a frosted glass pattern. And what this is the result of is the substantial amount of air that we take in when we eat. And then that gets all mixed in with the food bolus. And so, the sound waves that we're using for ultrasound don't penetrate air very well. They get reflected back very easily. And so you'll kind of get this frosted pattern, and you're only able to see that anterior wall. You won't see anything posterior. All those deeper structures, that we saw on our other examples, when we're kind of looking at everything, we could see everything beyond that. And here you won't be able to see that because of the air. Now, if we waited a little bit of time, the gastric context is going to become more homogeneous, okay? So that swallowed air is going to dissipate. Some of it's, going to bubble up and get released. And then we'll be able to start to see some of those posterior, deeper structures again. This also could be a similar image if a patient had drinking like a milkshake or thick milk sort of drink, you might see this as well. So this could be an image either for kind of late stage in the solids or, if they've had a thick drink to drink earlier. Obviously, either of these two images I've just showed you, these are considered full stomachs. These people are at high risk of aspiration, and you want to make your decision about timing of surgery based on obviously the urgency and other factors. And of course, you're going to treat them as a full stomach. So now we're going to look at clear liquids or just gastric fluid, okay? So if someone has drinking fluid or just has, gastric secretions in their stomach, what you're going to see is the antrum distended with just this hypoechoic contents, okay? Sometimes you can see, especially just like right after they drank, it's kind of fun to do this in the recovery room, just have them drink a little bit of Sprite or something, and you can see these little air bubbles, and they'll appear as mobile echoes, okay? So like mobile little fluttering, it almost looks like they call it starry night, okay? So we have the bullseye, frosted glass, and now we have our starry night. So if you detect clear fluid during gastric ultrasound, this is kind of where things kind of get more into, the nitty-gritty, okay? So easy if you see a full stomach, right? Clearly that's, you see food, you see those two images we saw earlier, full stomach, easy. If you see nothing, great, you can proceed with that. Now, if you see fluid, this is where we kind of need to kind of do some more digging, some more detective work. So you can do what's called a gastric volume assessment. And basically, you're trying to differentiate baseline gastric secretions, which we all have, with higher volumes. Now, higher volumes of gastric fluid or secretions can increase the risk of aspiration. And I think we've all seen this where we put somebody to sleep and then there's some regurgitation of that green bile-ish fluid, and we're like, why? They said they were MPO, why did this happen? And so this is kind of what we're talking about here. Now, of course, the upper limit of normal baseline gastric volume is still controversial, but most of the literature is accepting values and volumes of around 100 to 130 mLs, and that's typically around 1.5 mLs per kg. So that's kind of your upper end of normal there. If you have volume less than that, this has been routinely shown not to pose a significant risk of aspiration for those patients. So now we know kind of the volume we're looking for. How do we estimate the volume? So we get our image, we see the stomach. It's, we don't see food. That's great. We just see black, hyperechoic, fluid. There's some peristalsis. Okay, great. What do we do with this? How do we know that this patient is safe to go to the OR or maybe is not safe? So there's a couple different ways to estimate the gastric volume. And it has been consistently shown in the literature that taking the cross-sectional area, which is what we're going to do, of the gastric antrum, when we measure it in that right lateral decubitus position, correlates with gastric volume. So there have been several mathematical models that have been used to describe this. They've been validated with endoscopic guided gastric suctioning, so they know that there's accuracy. So how do you obtain the cross-sectional area? There's two ways to do it. The first way I have listed here, you can measure the anterior, posterior diameter, and then the craniocaudal diameter from going edge to edge, and then you'll plug that into the equation that you see here. Another way of obtaining the cross-sectional area is by using the free trace tool that you have on all ultrasound machines have it, and you'll just trace, you'll follow the serosa. You want to be on the actual muscle layer, so you'll follow the serosa all the way around the full thickness of the gastric wall. You obviously want to do this with the gastric antrum at rest and in between peristaltic contractions. And then as with anything with ultrasound, you want to take at least 3 measurements and then get the mean to minimize any sort of measurement error. So once you have your cross-sectional area, you can easily apply that to this table, which, thanks to all the work done by Dr. Perillis and her team, is available on gastricultrasound.org. It's not, I'm not promoting any sort of thing that costs anything. It's purely for education. The experts in this field have created this wonderful website to help encourage more people to do gastric ultrasound and to provide resources. So this table is available on their website, gastricultrasound.org. And what this table is based off of is this linear correlation between the cross-sectional area and gastric volume. And so I put the mathematical basis for the table underneath, which you certainly can plug your cross-sectional area into if you'd like, or you can just pull up this table and use it that way. And then, as I mentioned, a volume of less than 1.5 mLs per kg is obviously low risk for aspiration. We're all very busy, so if taking a measurement and trying to apply it to that mathematical model I just showed you is not something that you have time for, there is a semi-qualitative 3-point grading system that you can use as well. And this is to differentiate, again, between high and low liquid volume states. And just as we've seen with the cross-sectional area. So you're going to obtain the grade same way. You're going to image the antrum in the supine and then the right lateral decubitus. If both appear empty in those positions, then obviously there's a minimal amount of fluid, and this person is a grade 0, low risk for aspiration. If you see fluid only in the right lateral decubitus, when they're supine, you don't really see fluid. This is a grade 1. This is compatible with a fluid of less than 100 mLs, and therefore that's compatible with a fasted state. So that person is also low risk of aspiration. And then if you see fluid in both positions, this means that there may be more than 100 mLs of fluid, and that can be, obviously, as we talked about, greater than 1.5 mLs per kilo, and that's an excessive amount of fluid. So you may want to treat that person as a full stomach. They have more fluid and gastric contents in there than is baseline secretions. So this is kind of the bird's eye view. It may be difficult to kind of see this slide, especially from the back, but all this is really showing you is how you can apply this to your practice. And this is what we've kind of looked at, already today. You do your exam, stomach's either empty or has solid contents. That's easy, and you can see, those clearly delineated there. And then fluid, kind of goes down the screen here, we can, do that semi-qualitative exam, or we can move further down the line and do that volume assessment with where we measure the cross-sectional area, and then we use that model, okay? And then obviously, if it's less than 1.5 mLs per kilogram, that's low risk, you can go ahead. If it's more, then, those people are higher risk. You may want to do, either, an intratracheal tube or rapid sequence induction, all the things that you would normally do for someone at high risk of aspiration. So in applying this to clinical practice, I wanted to kind of look at a few things here. And this group, which published in the British Journal of Anesthesia, they looked at over 500 patients with ultrasound who presented for elective surgery, and they all followed the fasting guidelines that we looked at earlier. And while, again, I'm not advocating, scanning healthy patients who present for elective surgery, I think what they found, I wanted to illustrate what they found here because I think it's really important. They found that 6.2% of patients who presented after following those guidelines had a full stomach, whether solids or fluid over 1.5 mLs per kilogram. And only a fifth of those patients had a documented risk factor for delayed gastric emptying. So only a fifth of them would you have even been suspicious. And while, we all know aspiration events are extremely rare, I think this highlights a need for another modality to evaluate gastric contents than just relying on these fasting guidelines alone. This other group, also published in the British Journal of Anesthesia, scanned again over 400 patients, and this time patients presented for either elective or emergency surgery. And what they found was a full stomach in about 5% of patients that presented for elective surgery, and that's similar to what we saw with that other group. And then they found a staggering 56% of patients with a full stomach in the emergency surgery group. And the article didn't give me the exact time that they had fasted, but it was well beyond, our 8 hours, after a meal for those surgery emergency surgery patients. They found that obesity, diabetes, opioids, and obviously their emergency-related conditions were main risk factors for finding a full stomach. And again, I think this highlights another need for another modality to determine gastric contents rather than just a presumption of a full stomach for those emergency surgery patients. We all have seen that routine application of a rapid sequence intubation for an emergency surgery patient sometimes is harmful to certain patients with certain comorbidities. And some of those patients would benefit more from a slow, controlled induction. And so we can't routinely just put everyone who presents for emergency surgery into a full stomach category. And certainly, this applies to patients with difficult airways as well, who may require, more than one attempt. So hopefully I've shown the need to scan certain patients, but, you may be wondering, how accurate is gastric ultrasound? Now this group only looked at 40 healthy volunteers, but they did 2 exams, so they analyzed over 80 sessions, and they found that gastric ultrasound, when done by, people who had been trained, is highly sensitive and specific, and of course this is, again, respectively in situations where the pretest probability is at least 50%. So you can be confident, if you have a high index of suspicion, you can be confident in what you see. Now, of course, there are limitations, and so I wanted to mention a few caveats. Thus far, gastric ultrasound's not been validated in patients that have abnormal gastric anatomy, so those with hiatal hernias or prior gastric surgery. And also, just important to note, sometimes when the stomach is very small, it can be kind of difficult to identify, and so that may leave you with an inconclusive exam, and the stomach is empty. So. And then, while, as with most things, imaging can be difficult in morbidly obese patients, although several studies have validated the findings. So the findings are accurate, it's just they're more challenging to image. There are several, patient populations also that, can be, where this can be applied, but there are certain, special considerations and technical differences for these patients. So that was kind of beyond the scope of this talk. But no, if you are interested, there are scanning techniques for pediatric and even obstetric patients as well. So what I'm going to leave you with here is hopefully, an idea of that gastric ultrasound can be an effective tool to help determine if a patient is at high risk for aspiration. And like many of our other point-of-care ultrasound applications, I think this is something that's pretty easy to do. You typically have this equipment readily available, especially if you're doing a nerve block. You have the machine right there. And gastric ultrasound, just like with all other point-of-care ultrasound techniques, can be used to answer specific clinical questions to lead to a change in your anesthesia management, and then hopefully, keep your patients safer, keep costs down, and thank you very much.
Thank you, Dr. Chaco. And now, via Zoom technology, we are pleased to present Dr. Ashley Bailey Klassen. She's a quadruple board-certified interventional pain management specialist. She graduated from medical school from the University of North Texas Health Science Center, Texas College of Osteopathic Medicine. Then she moved to Red River to complete an anesthesiology residency at the University of Oklahoma Health Sciences Center. After her time in Oklahoma, she traveled all the way to Ohio to complete a pain fellowship in the prestigious Cleveland Clinic. She is a diplomate of both ABA and AOBA boards. She's also board certified in pain management by both the ABA and the AOBA, and after completing her training, she returned home to Texas to join Trinity Interventional Pain and Spine. So please help me in welcoming Dr. Klassen.
Hi guys, first of all, I want to apologize for not being able to be there. I want to thank the AOCA for the invite. I'm truly honored to be able to present to y'all. Part of what I want to go over today is some newer indications for spinal cord stimulation. So we shall get started. I'm also pretty honored to follow one of my esteemed classmates from medical school this morning, so that was kind of fun. So these are my disclosures. I do speak for a couple of different companies, as well as I'm an advisory board member for a couple of different companies. So what are my objectives for today? Well, we don't know where we're going if we don't know where we've been. So I want to go over some of the historical account of it. I want to go over some of what we postulate of what the current mechanism of action is, discuss some more recent publications, and then discuss some novel indications that have come out recently and where I think we're going. So, spinal cord stim, where did we start? So first account of the use of electricity for the treatment of pain was in 63 AD. Ascarbonius largus used a torpedo fish to treat pain mainly associated with gout. In the U.S., our own Benjamin Franklin was the first American to use electricity, but he deemed it ineffective and uncomfortable. For the record, he was using relatively high voltages. So yeah, I could see how that wouldn't be very, very comfortable for our patients. More modern applications. In 1960, Dr. Shealy placed some electrodes more traditional to what we see now, overlying the dorsal column, in an end-of-life cancer patient to see if we could alleviate some of their pain. The battery was not internalized at that point. It was attached to an external cardiac generator. The patient only survived a couple of days due to some other extenuating circumstances, but during that period, they did prove that this was an effective way to alleviate pain. Moving forward a little bit, in 1989, the FDA gave their first clearance for spinal cord stimulation for the treatment of pain. It was given for the indication of chronic pain from nerve damage in the trunk, arms, or legs. I'm kind of highlighting this because this will be important kind of as we move on. Oops, pardon me. So why did we think this worked? Well, Dr. Melzak and Dr. Wall went back and kind of looked at this. They came up with what they consider the gate control theory. They thought the substantia gelinosa did this central control summation of it by inputting this nociceptive and this anti-nociceptive input, and this modified signal was then sent rostrally to the brain. And this is kind of a very basic schematic of that. The way I kind of explain this to my patients is we're kind of tricking your brain into not perceiving the pain anymore. This was proven, and this was the main theory thought for a long, long time. However, some newer indications, we now think this is probably not the only thing that's going on. So what else is going on? Other potential mediators, obviously we're modulating serotonin, we're modulating norepinephrine. As y'all know, this is going to increase our GABA, this is going to suppress glutamate and aspartate. We also think there's a lot of modulation of the sympathetic nervous system in this. Some newer research has also shown that we are suppressing some hyperexcitability of the wide dynamic range neurons in that dorsal root. And more recently, Dr. Vallejo has shown that there is return of the microglia to a more normal phenotypic expression. This was done in a rat model, which we'll go over in a little bit. But mainly, this has been the status quo since 1989. This is how we have dealt with spinal cord stimulation. It has always been what we call paresthesia-based. So we have to, in effect, cover up your pain with a stimulation to be able to alleviate it. This has always put us in what we call, or what Dr. McHale always called, the 50-50 club. 50% of the patients receive 50% relief. And that's as good as we've had for a long, long time, which, considering where we came from, was really pretty good. So what has changed? Well, in looking back at some of our more recent studies, in 2015, Dr. Capel came forward with a study, the first level 1 randomized control study, comparing a different type of stimulation. So this looked at a 10 kilohertz or high frequency stimulation versus more traditional paresthesia based. They did show superiority for back and leg pain. This was done at 3 months, but this data was carried out both at 12 and since then 24 months. So it showed that our traditional spinal cord stimulation was kind of near that 50-50 club that Dr. McHale talks about. 43% for back pain, which has always traditionally been a little bit harder, and 55% for leg pain. For the high frequency group, they got up to 84% for back pain and 83% for leg pain. So again, this did show superiority, and this was the first level 1 randomized control trial going head to head. There is some postulation that this higher frequency stimulation stimulates more A beta fibers, while our lower frequency stimulation, again, as was discussed, does more of the A delta and C fibers. Moving forward from there, we looked at a different way to stimulate the dorsal columns. So traditionally, we've always laid those stimulators overlaying the spinal cord right in the midline. In 2017, Dr. Deere published a randomized controlled multi-center trial looking at what we call dorsal root ganglion stimulation. I'm sorry, I probably should have put a picture on here. This is kind of a mini stimulator that we can actually put out that neural foramen. Again, this showed that DRG was actually superior to normal traditional spinal cord stimulation for the indication of chronic intractable pain, usually related to CRPS, or what we call causalgia. Again, in 2018, Dr. Deere came out with another publication, this one looking at a different type of waveform. So this is the first time we actually looked at the waveform itself to see if we could modulate pain that way. This one is called the BURST trial because it revolved around burst stimulation. This was designed to be a more proprietary waveform and a more physiologic waveform, more what the body would produce itself to try and tamper down pain. Again, at 12 and 24 weeks in an intention to treat analysis, they showed that it was superior to traditional tonic or paresthesia-based stimulation. From there, again, I mentioned earlier that Dr. Vallejo was the first one to look and discuss that we've now seen that we can change the phenotypic expression of microglia, and he did that with the differential targeted multiplex stimulation. So Dr. Fishman went and took that research and published it in 2021 in a patient population. This was a prospective post-market trial, again comparing traditional paresthesia-based to this DTM or differential targeted multiplex stimulation for both back and leg pain. At 3 months, the responder rate was 80% in that DTM group, while again, the traditional paresthesia-based stimulation got to that 50-50 club at 52.2%. This was sustained at 6 and 12 months, and just to clarify here, what we consider a responder rate is the percentage of patients who got greater than 50% relief. So we've talked about waveform, we've talked about an area of the body to stimulate with that DRG, but we've never really talked about a therapeutic window like we do when we're talking medicines. So this study put out by my mentor, Dr. McHale, in 2020, was the first study to discuss closed loop stimulation. Again, this was a double-blinded level 1 randomized control study, and this looked again at that therapeutic window. So what they did is they delivered a small stimulation to the spinal cord and then read it at either end of those electrodes. When they read it, they determined the spinal response, or the way that stimulation was carried up the cord, and then modulated the next output so that we began to look at delivering our stimulation within this specific patient's therapeutic window. The first time this dose has been optimized, and they did show some superiority as well. However, all of these things that we've gone over so far, they've all been for the same indications, like I talked about earlier. Failed back surgery syndrome or post-laminectomy are most common. Complex regional pain syndrome, type 1 and type 2, or that causalgia. In some cases, you can also get by with intractable low back pain and leg pain. Eventually, some of our indications got expanded to chronic pain in the trunk and limbs. That's how we've gotten some of our stimulators placed in the cervical spine. DRG in the U.S., that dorsal root ganglion stimulation, however, is only on label for use in the lower extremities, or the lumbar spine, thoracic and lumbar spine. This is all we've had. We've been able to treat pain quite effectively, but we've only been able to use it for these common pain scenarios. And as we know, there are a lot more than just this. So in 2021, Dr. Peterson published a prospective multi-center open-label randomized clinical trial looking at spinal cord stimulation and the use for painful diabetic neuropathy. This was a head-to-head trial doing conventional medical management, so our gabapentin, our Lyricas, controlled regular blood glucose, things like that, against high-frequency stimulation plus all of that. The baseline visual analog scales for our control group, our conventional medical management, was 7. At 6 months, it hadn't improved much, 6.9. When we added in high-frequency stimulation, though, we saw a huge change. So at 3 months, that VAS went from 7.6 all the way down to 1.7. So adding stimulation, especially high-frequency stimulation, to that spinal cord for painful diabetic neuropathy shows a huge benefit. These numbers were taken at 3 months. However, again, this was carried out to 6 months and now 12 months, and it's looking the same for the 24-month data as well. Interestingly enough, when they looked at these patients, they also saw some neurological improvement. So we had this awesome study. What did it change? Okay, so we can now use it for painful diabetic neuropathy. Well, nobody covers it, right? Well, this company actually went back to the FDA and asked for this indication to be added. So in 2021, we got a new indication for the use of spinal cord stimulation for painful diabetic neuropathy. This has now been expanded to 2 different companies. Another company went back, presented a few more smaller studies that said they can do it as well. So we now have a whole new indication to be able to treat pain. This is our first new on-label indication for the use of spinal cord stimulation in 20 years. So in my world, it's kind of huge. For painful diabetic neuropathy, the World Health Organization estimates that a total of 422 million adults have diabetes. In the U.S., it's 34.3 million, and 10% of those are going to develop, 20% of those are going to develop painful diabetic neuropathy. It's 10% of the population in the U.S. With this indication, it allows us to have a drug-free therapy to be able to treat a much larger population. So we've got one more indication. Well, now we actually have two. We also had a company go back to the FDA this year in 2022 and ask for an expanded use of their device for the management of an intractable back pain when the patient's not a candidate for back surgery and back surgery hasn't been performed previously. My hope for this therapy is that this may prevent a lot of unnecessary back surgery for axial back pain. As y'all well know, the long-term studies when we look at back surgery strictly for axial back pain, they're not great data. And so my hope is that if we're able to use some of these devices in the long run, we can prevent having some of those unnecessary surgeries. So the reason they were able to go back and get this indication is in 2020, a meta-analysis was done from a couple of different prospective studies that showed the use of spinal cord stimulation decreased back pain by about 70% at 3 months. And this, again, was sustained out to 12 months. In pain, we're also trying to look at other things than just that VAS score, albeit a lot of the studies I presented today mainly were based on that because that's what their outcome measures were based on. A lot of places are also looking at ODI, which is your disability index, as well as opioid use. In this particular study, Al-Kaizi also mentioned that the ODI was dropped by about 15.7%, and overall the opioid use was halved. This combined cohort gave them a statistically sound group to be able to pull this data from. The way they were able to do this is for these patients, it was actually an FDA off-label use of this device, which we do from time to time, but having these FDA on label really makes it a lot easier with the insurance companies and allows us to really broaden this therapy for a lot more patients. So we've gotten 2 new indications, but where do we go from here? We have a lot more promising research now on the use for abdominal pain. I think this research will also show that we're able to use this for a lot more peripheral neuropathies. In Europe, they've already done a lot of research on the use for chronic angina pain and some headaches as well. I think we need to figure out why this is working. We've got some postulated theories of why this works, but we don't actually know. I think it's a combination of things. So where do we go from here? I think there's a lot more research to be done in the blended or combination therapies, some of which we discussed today. We also always have to be looking at our energy consumption because we are inputting energy into our patients that requires the use of a battery. So the better we can input that energy and decrease that energy use overall, the longer we're going to have use of our batteries. I think COVID has shown that we need to look at the way we program our patients as well. So remote programming is becoming a hot topic, as well as the use of salvage therapy. So we have these great therapies that we're putting in patients, and in some cases, they're not always used long term. What do we need to do to ensure that our patients are using them in the long run? Because of this, we are now getting the door open to a lot more patients, again, to be able to provide them a drug-free way of alleviating their pain, which, as y'all know, in our opioid crisis is pretty important. So these are my references, if anybody wants a copy, and I think we're holding questions to the end. So thank y'all very much.
Thank you, Dr. Bailey-Klassen. Now, please help me welcome Eric Smith, MD. He's a pediatric and adult anesthesiologist practicing at both the Children's Hospital in LA and Keck USC hospitals. He is also an attorney admitted to the California State Board. As for this academic background, he has a BS in bioengineering from UCSD, an MS in mechanical engineering from UCLA, another MS in physiology from Georgetown University, a JD from Duke University, and an MD from George Washington University. He did anesthesiology residency at the University of Maryland Medical Center, and then fellowship in pediatric anesthesiology at Johns Hopkins, where he stayed there as an attending before joining the faculty at USC and CHLA in 2020. His academic interests include health policy, health law, and quality improvement. He is an active member of the American Society of Anesthesiologists Committee on Professional Liability. Please help me welcome Dr. Smith.
Hello, everyone. Thanks for joining me. I was reminded why I have to pay off my student loans. Not forgiven yet. So I'm going to talk with you about medical malpractice, and I'm going to tell you what's wrong with the system and how we might go about fixing the system. The talk is not legal advice, definitely not. It's more of an academic discussion and some food for thought. If you do want legal advice, I would seek it from a true specialist in whatever area you have the issue in. I can only practice law in California currently, and I am a member of the AOCA Committee on Professional Liability. So we're going to talk about, again, malpractice, the shortcomings in the system, how we can fix this system, and then we will delve a bit into some anesthesia-specific considerations. There are a few slides I may skip over due to time limitations. If you want more information on them, feel free to ask me after. So what's the foundation of all this medical malpractice? It's a tort. So you can see the tort there from the Great British Baking Show. Similar but different. Not sure which one is better. But a tort in the legal sense is, if you go to Black's Law Dictionary, which is a legal dictionary, it says it's a legal wrong committed upon the person or property independent of contract. Of course, it's very legalese-esque. But basically, a tort is when someone is harmed and then the person is suing to try to get money, basically, or an injunction. So a tort has 4 components: duty, breach, causation, and damages. Without all 4 of those components, the tort will get thrown out. For us in medical malpractice, duty is usually that you had some sort of a physician-patient relationship, but not always. The breach is that duty that you had was breached. So for example, you could have a duty to the patient, but you fulfilled that duty, you didn't do anything wrong, so there's no breach. Causation is another required element. So whatever this thing is in question has to have caused the damages in question. And of course, lastly, we have damages. There are 2 types. One is actual damages, meaning the person's medical bills, their financial losses from work and so forth. And then there are also non-economic damages, which include things like pain and suffering, reduction in life enjoyment, and punitive damages. In medical malpractice, non-economic damages are commonly capped. So they're usually not out of control, which is good. And torts are always a civil action. When we're talking about this is a civil system. It's not a criminal thing. That's a completely different system, which interestingly has also been in the news lately. So why does this system exist? Well, it's because people and patients do get harmed. There was this study that I'm sure everybody has seen from Institute of Medicine that suggested that somewhere on the order of 100,000 patients per year are harmed during a stay in the hospital. There's some debate about whether that number may be a bit overblown, but that is a commonly cited statistic. Some suggest that medical error is the 3rd leading cause of death. Debatable, but that assertion is out there. In any event, if someone is injured, how do you make them whole? Well, the tort system is a way. It's not the greatest way. It's a very expensive way. So if we look at the system in general, it's very expensive. This ends up being about 2% of healthcare spending, which is on the order of 35 to 55 billion per year. And I should note this is 2015 data, so now that we have inflation, this is certainly much higher. For anesthesia, this has actually been specifically studied by Dr. Domino, and she said that the tort system seems to cost for anesthesia somewhere on the order of 5 billion per year, and 3.5 billion of that was in payouts. The rest was in overhead and administrative costs. Most of those payouts were settlements, 93%. Now, I should also mention this 35 to 55 and this 5 and 3.5 are from different sources, so when you look at them in proportion, it might make us look like we're worse than we are. We're actually pretty good. There is a suggestion that about 1 in 14 physicians are sued per year. I think it may actually be a little less in our specialty. There was a study that looked at whether these malpractice claims are legitimate. It looked like most of them probably were, but there were a whole bunch that weren't. So Atul Gawande, who you probably heard as an author, did this study, and he found that 3% of the claims that they looked at had no verifiable injury at all, which is not a lot, but it's still 3%. He also found that most of them involved medical error, and most of the ones that involved medical error did have compensation associated with them. But a good chunk of them, 37%, did not have medical error, and luckily most of them didn't result in compensation. But you'll see that there are gaps of people that were injured with no compensation and people that, injured with error with no compensation. And there are also folks that were injured without error that got compensation. So that seems like an unfair result. They also found, very importantly, that a huge amount of the money spent went to administrative expenses, 54%. So I'm going to skip this slide, but the key, well, I'll breeze through the slide. The key point is that most of the things were settled, and when it did go to trial, it was the plaintiff that, the defendant that won about 80% of the time, the defendant being us. So if we look at anesthesia data on defense costs, and this is the most recent data, but it is from 2013, so again, it's almost certainly much higher than this now. These are just the defense costs. So if you look at, if you got sued and it was settled, the defense cost is about $56,000 on the median, but it has a big range. Even sort of an inexpensive dropped suit is expensive. So we're very upset with the lawyers now. So Shakespeare said, first thing we do, let's kill all the lawyers. It's good. But interestingly, the character who said this is Dick the Butcher, and he was actually trying to create instability in the system to try to overthrow the king. So Shakespeare is, of course, brilliant and making a point that, yeah, we hate the lawyers, but they're also kind of essential because they're facilitating this system. John Adams, also president, said with no civilized society can do without lawyers. Of course, John Adams, a great president, but also a lawyer. A bit self-interested. So I think you probably have in your mind a lot of shortcomings of the tort system. There are many. I'll list a few. Opportunism. I think that Atul Gawande shows some of that. Atul Gawande's study shows some of that. There are unfair rules. There are cases that are wrongly decided. There are, of course, highly publicized, extraordinarily high damage awards that we find strange. There's an argument that it forces us to practice medicine defensively and do something that we think is not the standard of care, but instead some sort of legal defense. This leads to physician dissatisfaction, physicians leaving states that are high liability environments, and finally, one of the really bad shortcomings is that the injured parties don't get much of the money that's designed to compensate them anyway. If we look at that Atul Gawande study, they're only getting about half. So how could we fix this system? One way is through tort reform. So tort reform is when we change the laws to be better and make a better system. Usually when you say that to people, they're thinking about some sort of a financial cap. There are two kinds. One is an economic damage cap, saying that if you're injured, the most you could get is X, irrespective of what your damages were for medical bills, for example. There are also non-economic damage caps, say we don't want people to have punitive damages higher than $250K, for example. That was a law in California currently, but soon to change. There are I'm sorry laws or provider apology rules, which I think are actually very important. These are rules, or they're evidence rules or laws that say if you're apologizing to the patient or communicating with them, that can't be admissible as evidence of guilt. That's a pretty good strategy, I think. There are payment trusts and state funds where money is sent from the hospitals to a state fund. The most common type would be a birth injury fund, and instead of having the what would be a plaintiff claiming against a physician or hospital, that person can go to the state fund to get money for, say, a birth injury, again being the most common. There are statute of limitations restrictions where you say, okay, the person can sue after 1 or 2 years. They can sue within 1 or 2 years, but after that, you're stopped. And then there's something called joint and several liability versus this fair share rule. Won't get into it too much, but this has to do with if you have multiple parties that are defendants that are liable, there's a difference between divvying it up versus saying a lot of you owe $10 million and we're going to find somebody to get it all. There are contingency fee limitations where we say, well, we don't want the plaintiff's attorney to get 75%, but maybe 25 is okay. I'm going to sort of skip through these ones in the middle, but an important tort reform, almost a workaround that can be facilitated by the law, is a communication and resolution system, which we'll chat about in just a bit. And also safe harbors for evidence-based medicine is a strategy advocated by the AMA, which says, okay, if you have a physician that was practicing evidence-based medicine, but something bad happened, well, this suit will get thrown out. I haven't seen this actually come into fruition, though. I'll talk about 2 different states, but very briefly, because I know we're from a whole bunch of states. I've lived in California and Maryland for much of my life. California actually has something called Micromodernization Act of 2022, which, of course, to be confusing, takes effect 2023, January 1st. It does a whole bunch of things to change what was the previous MICRA, which capped non-economic damages, among many other things. But I highlight this in the busy slide because it does a whole bunch of things that are a bit confusing to understand. Important highlights are that apology laws, as written in this, seem to be much better in California than they were before. It used to be that you were protected if you made sort of a weird half apology that was vague, but now they seem to be, if this works, allowing you to have a sincere apology to the patient with full disclosure of what happened without that being admissible as liability of financial liability. Maryland, I'll put on here too, just because I used to live there, and also you'll see that the things that they chose to reform in their tort reform process is totally different than the California ones, with kind of subtly different angles. It's very hard to study tort reform because everything is all over the place, and there's such a time lag between enacting a tort reform and seeing whether it did anything, and there are a lot of other things going on in the world that could confound your data. Some people try to look at this, and they suggested that tort-reformed states have more physicians than non-reformed states, that with tort reform, insurance premiums in general went down when you compare it to the aggregate all going up, and that also defensive lawsuits was less expensive in reformed states. Interestingly, again, that 2% statistic is popping up where the whole tort system is costing about 2% of healthcare spending. Interestingly, this data was used during the passage of the Affordable Care Act as a justification to not have federal tort reform because they said, well, it's only 2%, it's not worth the effort. I'm going to skip past this one to talk about England. They have a better system, I'd argue, about how to deal with medical malpractice and injured parties. They really push people into mediation. They have trials that are decided by a judge, not a jury. Usually, medical malpractice trials that are decided by a judge probably come up with a more fair result. The loser pay attorney's fees in England. That deters people from bringing frivolous lawsuits that are likely to get thrown out or lost because the plaintiff's attorney won't want to eat that cost. And very importantly, 70% of their malpractice money goes to the injured party versus that 54% that Atul Gawande cited earlier. Now, there are some interesting workarounds and better systems. A really good one is the University of Michigan Health System communication and resolution system. What they did is they created this risk system where they internally look at whatever event has been brought to their attention, either by a potential plaintiff or by an internal incident report. They decided if there was a medical error, and if there was, then they apologized, acknowledged fault, and offered compensation, which was usually accepted. If there wasn't error, they told the potential party or potential plaintiff that there was no medical error and why. And then they would defend that lawsuit if it ever came up. The settled cases also, importantly, are in the university's name rather than the individual who may have been involved. Those then aren't reported to the national data banks or the medical board, which physicians usually prefer because you could be named in a lawsuit and have done nothing wrong or just happen to have been around, and it might be reportable to medical board when you apply for a license. When they looked at it, they said that their claims went down and that their dollars per claim went down. So that's good. There are other studies on something similar that said maybe with disclosure claims don't go down, although this example is a weird one. So UPMC looked at claims between 2002 and 2011. They had an interesting change in their law that said that hospital-acquired infections became serious events that were required to be reported, whereas before they weren't. So catheter-associated UTI or bloodstream infection would now be reportable where they're required to inform the patient that this had occurred. So they said, interestingly, claims didn't go up, but payouts did. But they also didn't have the system that University of Michigan did. So it's a little bit different, but I only highlight it to say Michigan's example, while I think it is good, is not the only example. So if we think about apology and how it impacts a patient or a family, does it work? Probably. If you look at other studies, they seem to, in aggregate, suggest that the payment size goes down, especially for severe injuries. And also, the patient's family usually, or inpatient, appreciate honesty and transparency and communication. Having an apology law in your state really helps this, but the apology laws in the different states are all over the place. A lot of the apology laws are very generic. They could be the same as for an automobile accident as for a medical professional, for example. There are some that have medical specific apologies, but they may be incomplete, where you can say, oh, sorry that this happened, but that's it. So the language is very key. I think that California one is very good. Just an interesting example, James Woods, the actor, recently was in the news because his brother had passed away for something that they were suggesting was medical malpractice. And he was really intent on pushing through litigation and not settling, and went on the record as such. But interestingly, the president of the hospital reached out to him and his family and said, yeah, we think that there was an error and we want to make a settlement. And interestingly, James Woods said that because they reached out and they were honest and transparent, he didn't want to pursue litigation anymore. He thought that they could make the situation better. And that some commentators on this said it's just the right thing to do, that many of us always practice honesty anyway, interestingly from a physician, because I think most of us just want to do the right thing. And then also another physician said it sets the stage for a totally different atmosphere where you can be honest and transparent versus trying to be confused, be in a very confused and defensive situation. Now, does it matter to us? Yes, so anesthesia was a really high liability profession a while ago, but it's gotten dramatically better such that we're at a less liability risk than average now. The ASA Closed Claims Project looked through a whole bunch of different closed claims to come up with different safety recommendations, which I'm sure you've seen. They have a bit of confounders in their data set, which they've acknowledged and I've listed there, but I won't go through them all. There's another database, CRICO, which is a Harvard Hospital's one, where they look at closed claims as well. There are insurance consortiums that look at these, and there's state data that looks at this as well. So it does matter because there is a safety element to it, and it may change the way that we practice. If you look at anesthesia data specifically, and this is 2013 information from Dr. Domino again, it's consistent with the previous aggregate physician data where most of the lawsuits end up getting settled. The ones that go to litigation end up being won by the defendant most of the time. Median payment then was about $330K in lawsuits. Again, 2013 data, so it's probably up from then. Premiums and costs also highly vary by states and the litigation environment that they're in. I'm going to skip the pediatric info. Anesthesia, of course, made great safety progress through the Anesthesia Patient Safety Foundation and all the other groups. The death rate used to be 1 in 6,000, which is quite high. Now it's less than 1 in 200,000. There have been much improved monitoring like anti-LCU and pulse oximetry. And we used to be almost 8% of the claims in 1972. Now we're about 3.8% of the claims in 2015, which is much better. Policy premiums in aggregate have gone down as well. This is in 2019 dollars. So as you can see, we're still in the downtrend. However, over the past 2 or 3 years, we've actually started to go up a little bit. Pain is a higher liability specialty. I mention it here with the graph just so we keep that in mind. It makes sense because, as our previous presenter noted, we're doing things like spinal cord stimulators, cervical injections, and so forth that are relatively high risk comparatively. So probably we all like tort reform, but there are a lot of people who don't like it, especially plaintiffs' attorneys or other groups that want to get more money. These are some arguments that they've made. Some of them have said, well, statute of limitation reductions actually encourage lawsuits. The logic there is that, well, if you say you have to sue within a year, then we better just do it now rather than waiting to see what happens. Some say, oh, anesthesia is a great success story of malpractice litigation. See, we made them safer. This was, interestingly, an argument that was cited in a couple of legal papers that I read. There was that argument that it's not a huge cost to the system at that 2% mark, so it's not worth addressing. I don't agree with that, but some people say it's not that big of a problem. Some argue that the caps are not inflation adjusted, therefore you should just have an unlimited cap. This is a fair point. The previous California non-economic damage cap was $250,000. Now it's gone up. It's still going to be about a little less than $1 million, but it will be inflation adjusted. So they make a valid point that the system for the cap could be flawed. Some say that the attorney's fees eat away at the damage amount, so you should have a really high damage amount. That way everybody gets something. It's noted that minor and moderate injuries aren't very well compensated, so it would be better if you could make a higher liability environment for the defendant such that you could extract more money. And there are a lot of people that argue that defensive medicine doesn't exist and that medical malpractice doesn't induce different behavior. The data, to be fair on that, is all over the place. So interestingly, even though there's a lot of tort reform that's positive, there's some reform regression that I've noted lately. Most of it has to do with widening the encatchment area in some way. And again, these are all state-based cases. So each state is totally different. There's a case, Warren v. Dinter, interesting one in Minnesota, where it's a complicated backstory, but basically a physician that was talking to a nurse practitioner on the phone got sued, and there was a question about whether that person could be sued successfully because there wasn't a documented physician-patient relationship. The Minnesota Supreme Court actually said, well, we are refining or reinterpreting our law to say, in Minnesota, the duty element is that there could be foreseeable harm. That's the question, not is there a physician-patient relationship. So that's Minnesota, but that's a trend there. Florida, for whatever reason, has a new law where you can basically discover almost anything in a patient's record, including things like peer review information, which in most states is non-discoverable, but it is in Florida. In Illinois, the Supreme Court said, as far as they see it in Illinois, non-economic damage caps are not constitutional per the Illinois Constitution, therefore they're unlimited there. And then I'm sure that you've seen the Redondo Vaught case, which is a criminal case that has to do with criminal conviction for reckless homicide and felony abuse of an impaired adult. The Anesthesia Patient Safety Foundation actually released an interesting and I think helpful statement saying that they thought the criminalization of medical error was contrary to patient safety and medical progress. So the take-home points: malpractice victims are probably poorly compensated. I think that number of 54% getting eaten up by administrative costs is unfortunate. If anything, you'd want a system where the damaged party gets money to help whatever their situation is, the system is extracting a humongous amount of money. That's probably not good. So some kind of reform is probably good. I think damage caps are pretty reasonable. Non-economic damage caps, I think, are totally reasonable. The California example is a good one. Economic damage caps, probably reasonable to cap it at something. Statute of limitation reductions, I think, are reasonable. Some states have a very expansive statute of limitations. For example, Maryland, for a minor, would let you go all the way through 18, then have a statute of limitations that could hold through 5 years. So to have it run for, say, 22 years or 23 years seems like a long time. California's is shorter, so it's more on the order of about 5 years for a minor, depending on the circumstances. That's probably good if you have something reasonable as a statute of limitations number. I think apology laws are actually really important. The California one that they have passed is good. It facilitates things like the communication resolution systems that University of Michigan and a lot of other places have. I think that's a great system. You need to have a big institution with a lot of money and a vision to do that kind of thing. It probably reduces your costs in aggregate, and it probably also makes damaged parties better compensated and better respected. But again, that's a good system. Peer review protection, something I didn't go into a lot, but I did mention with that Florida, the new Florida law, they are extraordinarily important. You want the medical system to be able to monitor itself, have frank discussions that are non-discoverable. That's the key. Mediation is probably a better system than litigation. Nobody wants to go to court. It's expensive. It comes out with weird results. You'd rather just work it out in less formal setting where you get a more equitable result. And then finally, very important is to inform yourself and be politically active. I actually had the opportunity to work in the Senate during the passage of the Affordable Care Act, and the Senate office that I was in received a lot of input from physicians and other medical professionals. They would all get databased, and the senator would actually look at whatever that input was, informing his ultimate decision on how to vote on laws. So those emails that you get or other suggestions that you get from your state society that say, hey, these are your representatives, send this email, click through this thing, it actually does make a difference, believe it or not. And then we'll talk about questions at the end.
Thank you, Dr. Smith. Now we're going to open for questions.
Oh, it is on. All right. Just a question on the peer review process and the Florida law. Does that Florida law overrule federal protections?
It's a good question because this has been litigated actually. There is a federal peer review protection which has to do with reporting to safety databases in particular. There's a different Florida case different than the one that I cited, where there was a fight over some information that was sent to a patient safety database and whether that was discoverable or not, because that information was getting processed in their internal event reporting system, and it would get parsed and then reported to the federal database, or federal required database, which is a federal requirement. So there was a legal fight about whether that was discoverable, the event reporting information. And the Florida Supreme Court said that yes, it is. I forget if it's Florida Supreme Court or the federal district court, but I think it's Florida Supreme Court. This is a Florida question. They said yes, it's discoverable because it's not exclusively for a federal purpose. So basically, they said only if you're collecting this information for the purpose of reporting to the federal system, which has the associated federal peer review protection, is it protected. Everything else is discoverable, which is a pretty draconian result because that means all of your event reporting is discoverable unless you're doing just to check a box off to send it to the federal government.
Thank all the superintendent this morning. I just wanted to make a plug for advocacy. because in Nevada, we had a history of like don't hold me to the dates, but around 2008, there were changes in the malpractice caps, and it became much more likely. The awards were much higher, and we had a massive migration of physicians out of the state to the point that women couldn't even get in to see an OBGYN for delivery and that sort of thing, and were showing up at the hospital with no prenatal care. It was a real crisis. It got addressed, and again, we thought you would think that would, forever set the tone that, if you do that sort of thing, you're going to jeopardize, especially a state like Nevada that already has a shortage of physicians, that you're going to jeopardize that physician population and the medical care in your community. But once again, this year, and it'll be the next the next House of Delegates or whatever, they're going to take up a motion to remove that cap. And it's already a known entity that the doctors are already saying they're gone if that happens, because things just went entirely berserk with insurance rates increasing 50, 100, 200% when that happened in 2008. So it's like memory is short, and legislators want to do things to get attention and get votes. So and of course the trial lawyers in Nevada are very strong. So I'm sure this is true in a lot of states. Just be aware and stay engaged. I would just encourage everyone to take that to heart, because a lot of things happen in the background and you don't know about it until the governor's signing the law, and now you got a problem trying to undo something. So that's my comment. And any comments you may have regarding that?
I'd agree with you, especially on the local and state level. Advocacy, I think, can make a particularly significant difference. It's a little challenging on the federal level, but as the saying goes, all politics is local, and a lot of the elected officials know that if the votes change 100 votes for or against them, that could get them in or out of office. So they want to make your voice heard often. And in chatting with lobbyists for ASA and MSA and CSA, which I've all lobbied with, they said that, and my experience working in the Senate, same. If the physicians come in person, that makes a humongous impact, because they don't often see physicians coming in, because we're working. So, but if a physician actually goes to their office or communicates with them, they typically take it pretty seriously.
So I have a question for Dr. Bailey Klassen, if she's available. Patrick Henson from Nashville. Dr. Klassen, perhaps I missed, you were talking about open loop versus closed loop spinal cord stimulation, and how the closed loop system is preferable and likely going to take over. So my question is, are there physical differences in the actual implanted system, or is it more of a modulation technique? And could current systems be converted, or how does that look in the future?
No, that's a really good question. The way I understand it, and this does get into a little bit of the technicalities of the specific company, the current electrodes that a lot of people implant are usable. It's just an input-output system. What does have to be changed is the actual IPG, or the brain of the system, so to speak. If an electrode is going to be able to deliver energy, it'll be able to receive energy the same way. So the actual electrode is usually not the issue. It's the IPG, or the battery itself. I'm unsure right now. That particular system is only utilized by one company. There is another company that's looking into some research as well to be able to enable it. It's not on the market yet. And in fact, that company that I did mention, that Dr. McHale published about, is in the U.S., but in a very limited market right now. It is currently available. As well as if it will be able to be inputted into current systems in use. Right now, probably not. I'm unsure if some of the competitors will be able to do kind of software upgrades, so to speak, of their current systems. But right now, no, it's pretty limited part of the limitations of that particular company is because that energy delivering is specific for each particular patient. Programming actually takes a significant amount of time because that therapeutic window is going to change from patient to patient to patient to patient. So you have to individualize it for each patient, which is why they've come to market in the U.S. with such a limited display so far. Did that answer your question?
Yes, thank you. That was great.
One other question for Dr. Bailey-Klassen. As a proud dad and a partner, I have to say that was a great lecture. Just wanted to add the fact that we're now able to use these adapter cables and take people that have leads from other companies other than the one that makes the HF10 and adapt them, and we're getting some really comparable results. And I think you may have, Dr. Bailey-Klassen may have had the same experiences as I have with these adapter cables.
Yes, that sounds like a very familiar voice there, just saying. Yes, we do have cables that we can interchange some of these companies to others and vice versa. That's part of what I mentioned with some salvage therapy going forward. Actually, Dr. Fishman is looking at some specific salvage therapies between some current companies right now. And then going forward, they're also looking at possibly going back and reprogramming old systems to see if people that weren't responsive to, say, a paresthesia-based system after a period of time might be more responsive to one of these newer waveforms.
Okay. Any other questions? Going once? Going twice? Sold. Okay, thank you very much. We'll have a break and then we'll continue with our second session.